Good afternoon, everybody. Welcome to our, believe this or not, our final episode of the APDR National Virtual Noon Conference Series. I can't tell you how proud I am of all of you for attending. The outpouring of generosity our speakers have had. We are in the final week 17. You are going to hear lectures 67 and 68 of this series. We've been going for a long time, and we really hope that this has been beneficial to all of you out there, both domestic and abroad, on bridging the gap of your education during the COVID-19 era. We sort of come to our conclusion here, and we hope that you continue the vision for education, and wish you the best of luck moving forward. If you'd like to follow a couple Twitter handles, there may be announcements for other educational programs in the future. You see those at the bottom, the APDR and myself, as the chair of the education committee for the APDR. If those are handles you want to follow, that'd be great. As you know, the lectures are all recorded. They have been recorded since the beginning and hosted on the APDR YouTube channel. We hope that you visit that channel and benefit from the talks you haven't heard. In addition, please go to the APDR website and see all the educational resources and assets that we have on the website to offer all trainees from that standpoint. So again, this webinar, like everyone else, has been recorded, hosted on the APDR YouTube channel. The questions and comments are being recorded. As you know, your microphones are muted to ensure optimal quality. And if you have questions for the presenters, we ask that you use the Q&A tool. Before I introduce the speakers, I do want to make one more, thank you. I can't tell you how much I'm grateful to the APDR staff with Kara and Lauren. They've been working on this with us from the beginning. Their dedication has been really wonderful. So thank you both so much for everything you've done for this program. Without further ado, I'd like to introduce our last two speakers for the noon conference series. Dr. Connolly, Instructor of Radiology at the Harvard Medical School and Director of Nuclear Medicine at Mount Auburn Hospital. Caitlin will be speaking on on-call nuclear medicine to start the session. And Dr. Umesh D, a good friend of mine down in Texas, Baylor University Medical Center Associate Professor of Radiology and Vice Chair of the department. He'll be speaking on CNS nuclear medicine review in the second half of the session. So without further ado, thank you all for everything you've done for the program, and I will introduce our first speaker on this last session, Dr. Connolly. I'll stop sharing my screen, and if you'd like to take over the screen share, that would be great.
Okay. I want to thank Harvard and the APDR staff for organizing this conference series. I know it's been wonderful for the residents. Sad to see it come to an end. And I'm delighted to be here to talk to you all about on-call nuclear medicine. I thought it would be pertinent, the timing. I know our second year residents are starting their overnight call. And for first years, these are common cases you'll see in your nuclear medicine rotations and going forward. So I'll talk about ventilation perfusion scans, hepatobiliary scans, GI bleed scans, and brain death scans. It's not an exhaustive list of things you might see on call, but common things that come up on call. So for ventilation perfusion scans, questions to ask when you get called to protocol a VQ study. And you'll see this is a theme, but is the patient stable to come to the nuclear medicine department? I don't know about your nuclear medicine departments, but places I've been, often nuclear medicine is in the basement or somewhere somewhat isolated. We're lucky enough to be sort of integrated with the cardiology imaging center, but there's nobody around in the middle of the night. So for the sake of your nuclear medicine technologists and the patient, don't have an unstable patient come down to nukes where there's no nursing and nobody to really help in the middle of the night. For VQ scans, you need a chest x-ray that's current, so within 24 hours to interpret the study. The patient needs to have IV access. It's helpful if they can follow commands, especially for the ventilation portion of the study. If they're pregnant, you might alter your protocol, so that's important to know. Let's see, here we go. So here is our our protocol. It may vary somewhat institution to institution. So for perfusion, we use technetium-99m macroaggregated albumin, that's MAA, and obtain usually anterior posterior and left and right anterior and posterior oblique views. And then we also do a right and left lateral view, but those are sometimes omitted. Normally, there should be diffuse uptake throughout the lungs with no extrapulmonary uptake. And in pregnant patients, our protocol is to decrease the dose by half and omit the ventilation phase. We also, in the sort of COVID era, have omitted ventilation in most of our patients at this point, sort of following the guidance of the Society for Nuclear Medicine and Molecular Imaging, and also the ACR concern for aerosolizing COVID in these patients, since the patients coming in for BQ scans are often, short of breath, tachycardic, other symptoms that can go with COVID. So, that's probably institution dependent, and sort of just follow the protocol of what your institution is doing. But right now we're omitting ventilation unless they've tested negative for COVID. So here's an example of a perfusion study. So here we have on the anterior view, you can see the heart shadow here, and then you have the mediastinal contours, but you should have diffuse uptake following the contours as you see them on the chest x-ray. If they have an elevated hemidiaphragm, they may have decreased perfusion there as well. So make sure you can see sort of the contours of the whole lung. So that's a normal perfusion scan. For ventilation, there are two different ways to do ventilation. One is using xenon-133, which is a gas, and that is done with dynamic imaging. So they basically have three phases. You have your single breath phase, where they take a deep breath and hold their breath. And then you have an equilibrium phase where they're breathing xenon mixed with oxygen, and that lets you to see the whole aerated volume of the lung. And followed by a washout phase where they breathe fresh air and you obtain images, and it can demonstrate air trapping. So here is an example of a xenon study. So these are obtained in the posterior oblique, both left and right posterior oblique views. You can obtain them in whichever, if you have a two-handed camera, you can get two views essentially throughout the study. So some places do it anterior posterior. It's sort of up to the protocol, but in this case, this is the tubing that's external to the patient. And we see the wash-in phase here, and then equilibrium and washout, and there's no real air trapping. So this is what you're looking for in both lungs here. So that's xenon. The other way of doing a ventilation scan is with technetium-99m DTPA, which is aerosolized, and it's inhaled using basically a nebulizer setup and deposits in the lungs. And because it deposits, you can then image multiple projections. So typically you image the same projections as the perfusion imaging. So here's an example from the literature, and the box in yellow is the ventilation portion of the study here, and the top is the perfusion. And so you can do direct comparison on all your views. Often some of the DTPA deposits in the mouth and is swallowed, so you can see stomach, this is stomach here, and esophagus uptake. In terms of interpreting your BQ scans, this is from the Society for Nuclear Medicine and Molecular Imaging guidelines, but typically PIOPED or modified PIOPED criteria are used. And I always encourage the residents just pull up the guidelines and have them, you don't have to necessarily memorize them when you're on call, just pull them up and look. But for high likelihood ratio, 2 large mismatched segmental defects, so a large defect is at least 75% of the segment, and then normal if there's normal perfusion, and then there's different categories in between. I won't review all of this because that's sort of a whole lecture in and of itself, but you can always have the guidelines while you're on call and look at them. And just a reminder about the segmental anatomy, I encourage residents to pull up the segments and you can see, is it a segmental abnormality? So there's lots of different ones online with all of the different segments in the views, so you can see where they would be in the different views. So here's some cases. This is an 80-year-old woman who presents with chest heaviness and dyspnea for 3 days. She had increased troponin, so the clinical suspicion was for a myocardial infarction, and she underwent coronary catheterization, which was normal for her coronaries, but she had a dilated dyskinetic right ventricle, and she also had acute unchronic kidney injury. So here is her chest x-ray, and you can see she's got some scattered granulomas, but her lungs are essentially clear. Her heart is top normal size. She's got a bit of a tortuous aorta, but nothing really focal in the lungs. This is her ventilation scan with xenon in the posterior projection. And you see both lungs sort of well outlined here. Again, this is external to the patient, that's the tubing, but you see ventilation to both lungs. And here is her perfusion imaging with technetium 99M MAA. And you can see that there are some wedge-shaped peripheral perfusion defects. And I've overlaid the segment map here to show you kind of all the different areas. But there's overall asymmetric perfusion to the left lung, decreased compared to the right. And then there's also segmental perfusion defects in the apico-posterior segment of the left upper lobe, the inferior lingual segment of the left upper lobe, which you can see here in yellow, the superior segment of the left upper lobe, and then the anteromedial basal segment of the left lower lobe. And then in the right lung, there's perfusion defects in the apical segment of the right upper lobe and the medial and lateral segments of the right middle lobe. So multiple perfusion defects, which are segmental and mismatched. We didn't see these on the ventilation portion of the exam. So definitely more than 2 large mismatched perfusion defects. So this is a high likelihood ratio of pulmonary embolism. And there's a large clot burden. And what they were seeing on the cath was right heart strain, the dyskinetic right ventricle. She also, on further evaluation, had bilateral DVTs. Here's another 80-year-old woman with acute onset of chest pain and shortness of breath. Also thought she was having an MI, and they did a coronary catheterization, which was normal. Here's her chest x-ray. You can see her heart is enlarged, low lung volumes, but essentially clear lungs. She does have some widening of her mediastinum, but this is just vascular tortuosity. She'd had a prior CT. Here's her ventilation with xenon, and you can see we do both the posterior oblique right and left here, and fairly normal ventilation to both lungs. You can see it's sort of the whole outline of both lungs. And this was her perfusion scan with technetium MAA, and you can see here it looks like, you know, whole puzzle pieces of the lung have been taken out. So these are large segmental defects, multiple segments. Again, I didn't overlay each one, but superior segment of the right lower lobe, the right middle lobe, and also on the left side. So she's got, again, multiple segmental perfusion defects. So it's high likelihood ratio. All right, moving on to hepatobiliary imaging. So questions to ask when you're called to protocol a HIDA scan. Again, is the patient stable to come to nuclear medicine? HIDA scans take sort of up to several hours, and you don't want somebody who's unstable coming down in the middle of the night. Also, just as an aside, we don't have nursing in nuclear medicine. Don't know about other departments, but most of the time, you know, if they're on monitors or something like that, and they might need nursing to come down with them. So just sort of make sure the team knows that when you protocol it. It's important to know when when the patient last ate. So if they're looking for acute cholecystitis, they need to be fasting for at least 4 hours. And if they've been fasting for more than 24 hours, their gallbladder may be full of bile and distended with bile, so more won't easily go in, and that can be a false positive. So it's ideal to treat those patients with CCK to contract the gallbladder prior to the study. They need to have IV access. And The HIDA scan is done with technetium-99M labeled mebufotenin, which is actively transported into the hepatocytes and secreted into the bile without being conjugated. You need to have functioning hepatocytes, so folks need to have, if you have somebody with severe liver dysfunction, you might not be able to get a diagnostic HIDA scan. Normally, the blood pool will clear by 5 to 10 minutes with liver uptake and excretion into the biliary tree, and you should see gallbladder and bowel within 60 minutes. And on call, the indications you'll typically see are acute cholecystitis in the setting of usually equivocal ultrasound imaging. This is not your first line imaging modality. Usually ultrasound is, but sometimes those findings are equivocal, and this can be a problem-solving technique. Also, bile leak. The HIDA scan can sort of prove that fluid around the liver and the gallbladder fossa after cholecystectomy is from a bile leak. The HIDA scan is also useful for chronic cholecystitis and biliary dyskinesia, but that's not typically an emergency on-call case. So here's a normal HIDA scan. Each of these images is 1 minute. So starting here in the right upper corner here, we have, or I guess radiologist right upper corner, the left upper corner. You see blood pool with, here's the heart here, the vessels, aorta and iliac vessels, and you're starting to see liver. And then by 5 to 10 minutes, basically the blood pool has cleared, we just see liver. And then you're starting to see sort of increased uptake centrally in the liver, which is the biliary tree. And even by 10 minutes, actually, we're starting to see gallbladder. So this is gallbladder, and it gradually fills with the mebufotenin. And you can see, it's sort of filling up over time. Now we're at 30 minutes, kind of going back towards the right lower corner here. And we see also small bowel. So you're seeing bowel. This is coming out and going across into the jejunum. So this is a normal study. You see both gallbladder and bowel. So both the common duct and the cystic duct are patent. You can also do a right lateral image if you're not sure whether it's gallbladder or maybe bowel superimposed in the region of the gallbladder. And here we see gallbladder pointing anteriorly. And you can correlate with whatever prior imaging they had with the ultrasound or if they had a CT to see where the gallbladder is, but typically it's oriented anteriorly. So HIDA scan is over 95% accurate for detecting acute cholecystitis, and the diagnostic criteria are non-visualization of the gallbladder after 4 hours or after 30 minutes when giving morphine. Morphine contracts the sphincter of Oddi and helps increase back pressure so that bile will flow into the gallbladder if the cystic duct is patent. Causes of false positives include if the patient is not fasting, when you eat, the pancreas secretes CCK, which contracts the gallbladder. So if the gallbladder is contracted, it won't be able to fill. If the patient has been NPO for more than 24 hours, as I said, it may be filled with bile already, and they're just, it's the path of least resistance is down into the small bowel rather than into the gallbladder. You can try to overcome that by pre-treating the CCK to empty the gallbladder if the cystic duct is open. Hepatic dysfunction, so if you're not sort of actively able to have the hepatocytes taking up the tracer and excrete it, you won't really be able to assess. And then if they're on TPN, it's essentially like they're not fasting. So that's something to keep in mind. All right, so here's a 37-year-old man with right upper quadrant pain who has equivocal right upper quadrant ultrasound. And these are 5-minute images, but you can see, we see liver. And then at 7 minutes here, or 5 minutes, yeah. So this is minute 15. We see bile coming into the biliary tree. You're seeing coming down the bile duct and then seeing small bowel here, but we never really see anything in the region where we expect to see the gallbladder. We gave morphine, still no gallbladder showing up. Here's the right lateral, and again, we don't see anything that looks like a gallbladder. So this was consistent with acute cholecystitis, and he had acute cholecystitis at the time of cholecystectomy. Here's an 81-year-old woman with right upper quadrant pain. She had cholelithiasis and there was a stone in the distal common bile duct, but she had normal LFTs. And here's her HIDA scan. Each of these is 1 minute. And you can see liver. We see the bile tree showing up here, small bowel, but no gallbladder. Usually expect gallbladder to be here. And this is the second half of the hour, so 35 minutes. Again, no gallbladder. We do have slightly increased uptake in the liver along the gallbladder fossa. And here's just the cine view of that same. So again, you're seeing excretion into the small bowel and some slightly increased tracer along the gallbladder fossa. We then gave morphine and still no gallbladder, but it's sort of even more able to see that increased tracer. So that's called the RIM sign. And again, here's a cine, just so you can see it kind of play out that way. Right lateral, again, no gallbladder, and she had gangrenous cholecystitis at time of cholecystectomy. So here's a patient who's 25. She's status post-cholecystectomy, and she has diffuse abdominal pain. She's also recently postpartum. She had a CAT scan, which shows fluid around the liver as well as around the spleen, and then going down the paracolic gutters into the pelvis. And there was some question of whether this was related to her C-section or this was related to the cholecystectomy, which was only a couple weeks ago. So she had a HIDA scan, and this patient does not have a gallbladder, but you see tracer going into the gallbladder fossa, but then also down the right paracolic gutter, over the top of the spleen here, over the top of the liver here where it's getting brighter. So this was consistent with a bile leak, and the bile is flowing diffusely in the peritoneal cavity. All right. GI bleeding studies come up not infrequently on call. Questions to ask when you're protocoling a GI bleed study. Again, is the patient stable to come to nuclear medicine? This is especially relevant with GI bleeds because oftentimes patients are unstable. If the patient's on pressors and massive transfusion protocol, please do not send them to nuclear medicine. You need to know if they're actively bleeding and they need IV access, which hopefully they have in the setting of a GI bleed. Indications for a GI bleed study is to identify the source of the bleeding to help direct angiography in IR or surgery. It's generally not helpful for sort of the slow GI bleed with guaiac positive stools where there's sort of slowly downtrending hematocrit, but no melena, no hematochezia. Those tend to be too low to detect. And they need to be hemodynamically stable enough to come down to spend a significant chunk of time in nuclear medicine. Obviously, if they're actively bleeding and you see it, as you start the exam that they're briskly bleeding, please do not keep them in nuclear medicine for an hour. You should stop and send them, to IR or wherever, surgery as the case may be. But so in hemodynamically unstable patients, the ACR appropriate criteria is 1, which means not appropriate. In terms of which study to do to look for GI bleeding, if you have a lower GI bleed that's actively bleeding but hemodynamically stable, basically colonoscopy, tagged red blood cell scan, or CTA are all considered appropriate, and angiography may be appropriate depending on the clinical scenario. The sort of literature says that tagged red blood cell scans detect 0.05 to 0.1 ml per minute, whereas CTA detects greater than 0.3 ml per minute, and angiography detects 0.5 to 1 ml per minute. So tagged red blood cell is about an order of magnitude more sensitive than angiography. And you also have temporal sensitivity because you can image over 60 to 90 minutes. If they're bleeding intermittently, you have a longer time where you might be able to capture that bleed, whereas CTA or angiography, you just have the short time when you're kind of injecting the contrast to see the bleed. So you have a little bit more time if they're only bleeding intermittently. So this is a 58-year-old man with extensive peptic ulcer disease presenting with hematemesis. And you can see it's normal to see the blood pool. So we see heart and vessels. You see liver and spleen. And then we see this focus that appears and then kind of squiggles through the left upper quadrant. And you can see it's kind of progressing through what would be the small bowel. You know, colon typically runs this way around the abdomen down to the rectum. So if you have a bleed somewhere in the colon, it will usually, sometimes it can go retrograde, but it will follow along the path of the colon. Whereas small bowel, as you know, is much more tortuous and longer. And so you'll see it kind of moving along. So you're looking for a focus of tracer that's extraluminal in terms of extravascular, and then travels in what you'd expect to be the distribution of the bowel. And just to show, so you can see the sort of focus appears here, and then you see it moving along. And blood is very irritating to the bowel, so it tends to peristalse quickly through. So you can see it moving along. So this, he then went to angiography. This is a celiac injection. He's previously had embolization of a renal part of his kidney, so that's not related to the current situation. He had had an upper endoscopy where they saw an ulcer and they put some clips. So these are his clips from his endoscopy. And you can see right in that area, after the injection, you start seeing this blush here, which does not look like it's in a vessel, but sort of follows the contour of the mucosa. So this is in the proximal duodenum at the site of an ulcer. He was bleeding there. So they were able to embolize that. So that was a good outcome for him. Here's a 75-year-old man with bright red blood per rectum. And we can see basically as soon as we start, there is abnormal red blood cells here, kind of at the cecum, terminal ileum right here. It's a little bit hard to tell whether, I think it probably starts in the terminal ileum and then goes into the cecum. And you can see it's definitely following large bowel here. And so, you know, there's no need to keep imaging here. He's obviously bleeding pretty briskly. You want to get him off the table before he gets hemodynamically unstable, but they were able to take him to IR and embolize this. So you're helping to guide kind of location so they don't have to do injections in all the vessels, and it's helpful for guiding that. And again, here is our full study. We stopped at 30 minutes. There's no need to keep going. All right, and then quickly, because I'm running out of time, I'll briefly talk about brain death studies. This comes up fairly infrequently on call, but occasionally if the patient is a organ donor and they're trying to expedite the workup, you may do a brain death study on call. Brain death studies are to help as an additional piece of information in the clinical picture, but it's not sort of diagnostic. You need the whole clinical picture supporting brain death, and then this is an added piece of information. So you want to know if neurology has evaluated the patient and the exam is consistent with brain deaths clinically. They do need IV access to do the study. And there's different agents you can use. There's agents that stay intravascular and just show you blood flow, which either technetium-99m, DTPA, or pertechnetate will do. Or there's agents that will cross the blood-brain barrier, which ECD or HMPAO will do, and that allows you to look at the perfusion. And in the setting of brain death, you have increased intracranial pressure, so activity will enter the carotid arteries but not extend into the skull base because of the pressure. And you can see increased uptake in the external carotid territory, which is called the hot nose sign. And if you're using a perfusion agent, there'll be lack of cerebral activity on the static images. Just as an example of a normal perfusion study, you should see this is done with ECD, and it crosses the blood-brain barrier, and you have uptake in both cerebral hemispheres and the cerebellum. And again, you can do a SPECT to look in 3 dimensions, and it shows you uptake in the both cerebral hemispheres. So this was a 55-year-old woman with history of depression, found hanging in a suicide attempt, and was asystolic at the scene, was resuscitated. And you can see the bolus was injected here. This is with ECD. And you see the tracer going up the internal carotids to the level of the skull base, but nothing intracranially. You're seeing increased flow to the external carotid territory, with the hot nose, and we don't see any intracranial uptake. This was a perfusion agent, so you can look for intracranial perfusion, which we do not see here as opposed to the normal study you saw before. There's increased flow to the scalp and then the nose. And so that would be supportive of brain death if the clinical scenario fits. It's an added piece of information. One last case, this is a 60-year-old woman who choked on a piece of fish and had PEA arrest for 15 minutes. Again, you see the bolus come up the arm, coming up the carotids, but not extending into the intracranial vasculature. And then there's no uptake on the static images here. We also do imaging of the injection site to prove that you didn't extravasate the dose and it's not all sitting in the arm. And also we look at showing that we have dose systemically. So we know that the dose did get injected. And then this patient also had a SPECT, and you can see there's no intracranial perfusion. So that would be, again, supportive of the diagnosis of brain death if that clinically fits. So in conclusion, make sure your patient is stable enough to come down to nuclear medicine. Talk with the ordering clinician ahead of time to make sure that you're doing the right test to answer their clinical question. I think this comes up often with VQ scanning and sort of setting their expectations ahead of time about what information they might gain from the study. Also with GI bleeds, if the patient is not actively bleeding, we will not see a site of bleeding, things like that. So having those conversations ahead of time so that you make sure you're really doing the right test for the patient. All right, thank you so much for your time and attention. I'll turn it over.
All right, thank you. First, I want to thank HARP for allowing me to do this and inviting me to do this. And I think you guys have greatly benefited from his idea, and of course the leadership and support staff at APDR for allowing this. So my talk is going to be on CNS nuclear medicine, and we're going to learn a few things here. We're going to learn the common indications to do CNS disease and conditions, what we're trying to diagnose or further elucidate. We're going to talk a little bit about radiopharmaceutical pathophysiology, and then we're going to differentiate various examinations in evaluating cognitive decline. And I'm going to talk a little bit, Dr. Connolly actually talked a little bit about what I was going to talk to you about, so I can skip over that. Perfusion imaging of the brain, a little bit about cerebrovascular disease, tumor imaging, epilepsy, CSF imaging, and as well as dementia. So I'd like to always start lectures with a few intro cases and questions and sort of do a pre-test on you guys. So think about this question a little bit. You can read it on the slide there. And what would you think is this most commonly affected in Lewy body dementia? And then what is the most likely diagnosis? And this will be the greatest short-term recall ever in your life to see if you understood what Dr. Connolly just taught you and see what you think of this patient. And then here's a study looking at the brain, and they have some sort of memory issues, and what you think the most likely diagnosis is in this patient. Okay, and lastly, what is this study shown here, and what is the most likely diagnosis that you can come up with? You're not expected to know these things. Hopefully you'll learn what all these things are and the answers to these questions. If you already knew the answers, kudos. All right, so just overall, we do planar, SPECT, and PET-CT imaging. You already know this, but just sort of reviewing this, and this is for perfusion imaging and all kinds of dementia imaging that we do. So in brain perfusion imaging, let me just go quickly on this because Dr. Connolly covered that. He also talked about the different tracers. So I apologize if someone's watching this on video. Watch Dr. Connolly's lecture first. The technique, we'll just skip that. So here's the normal angiographic phase in those tracers that stay intravascularly. And here is a little bit of blush activity. I wouldn't call this totally normal brain. This person's not going to walk out of my hospital anytime soon, but definitely you can't say there's absent cerebral perfusion. And in a patient like this, on the delayed images we can get, you will not see activity in their brain because it doesn't bind to the brain, DTPA, but you will see the sagittal sinus here light up like this, and that's a sign that there is intracranial flow. I'll skip this slide because this is normal for the brain binding agents. This would be abnormal, as everyone can see. It's kind of a light bulb sign here with absent central tracer localization. We'll skip over that one and that one. And we talked about sort of nuances earlier. Injection bolus, you got to have a good injection bolus if you're going to use DTPA. If there's an abnormal, slow injection or the injection fails, those kind of things, that's a real problem, diagnosing brain bleed or brain perfusion. Hot nose sign, some people believe in it, some don't. It's definitely, you'll see it in patients, but there are a lot of false positives for hot nose sign. And sometimes you'll see no arterial flow and you'll see sagittal sinus activity on delayed images. And those patients, typically that's scalp activity. Your scalp veins actually drain intracranially, and then they can show up in the sagittal sinus. And just in general, hammer this point again, we never say brain death in our dictations. You always want to comment an absent cerebral perfusion or brain perfusion, depending on how much imaging you did of the brain. All right, so here's really where the lecture should be starting. We'll talk about SPECT brain imaging for using two agents, HMPAO Suratec and ECD Neurolite. They both bind to the brain, they're lipophilic, there's no redistribution. So once you inject the tracer, you image 30 minutes, an hour, 3 hours later, depending on the patient and transport, you can still have that snapshot image of which time you gave it. It's about how much dose you give. You obviously want to reduce external stimuli because that will light up parts of the brain that you don't want to, and you image within 15 to 20 minutes. So here's a normal SPECT brain. The highest uptakes in the gray matter, and the subcortical gray matter has the least, sort of showing blown up. And I like this GE color, and it shows it very nicely. Kind of the occipital lobe is lighting up, probably because they're looking around and lighting that part of the brain up. And so the clinical applications for SPECT perfusion are these four domains in pathology, but all I'm going to concentrate on are cerebrovascular disease and epilepsy. All right, one thing you must know, and these are kind of core principles during your residency, and I apologize, those are in fellowship or maybe even out of fellowship, but these are kind of basic things we expect you to know as nuclear radiologists through CNS imaging. And so acetazolamide crosses the blood-brain barrier and causes increase in blood flow to the brain. So we can actually use it as almost like a stress agent. The neurosurgeons worry the patient has carotid stenosis and wants to know if they bypass that carotid downstream, the vessels that supply that part of the brain, right side or left side, has enough flow to it that they can benefit from a bypass or stenting or endarterectomy of that carotid vessel. So what we do is we inject the patient with acetazolamide and increase the blood flow to the brain, and then we image. We inject the tracer and then image. Then we do a baseline study, usually the next day or 2 days later, and compare it. And to me, I tell my residents, look at it as a stress rest study. You stress the brain by increasing blood flow are normal. So pre, meaning before acetazolamide was given, and post, after. And we're going to look at it kind of in a column. I know most of us are used to looking at it kind of top row, bottom row, but imagine this is the same patient pre and this is the patient post. And so when you look here, here's diminished perfusion without the acetazolamide. But once you gave it, look at the diminished activity. And this is a rainbow scale, so you can see that's less activity there. And it's more so kind of near the right temporal lobe. And this is all kind of MCA territory. And here's sort of pre-acetazolamide diamox, and then after, look how much it just disappears. So this brain in here, right frontal and temporal lobe, are susceptible to any diminished perfusion and can eventually infarct. And so this patient would benefit, just like you would tell a cardiac surgeon or cardiologist that their LAD shows ischemia or reversibility or flow reserve issues, and they would benefit from some sort of stenting or bypass, and that's what we're doing here. So that's a diamox study looking for any kind of underlying flow reserve problems. All right, and so let's jump into brain tumors on PET-CT. And usually what we find it's an incidental finding when we're looking at FDG PET-CTs. And then you want to introduce yourself to gallium-68 dotated. Most of the institutions probably do dotate scans, but there's a few things you want to look for there. We also do radiation necrosis versus GBM recurrence using F18 FDG PET-CT, and then a few incidental findings we'll talk about. So this is kind of what brain metastasis looks on PET. Majority of the brain metastases we'll never see on PET-CT for two reasons. One, they're small, and two, most of the activity goes to the gray matter, which is where it happens to be where brain metastases occur, at the gray-white matter junction. So we're not going to be able to see them. But when they do occur and they're big and there's a lot of vasogenic edema, like in this case, you see the spot there all the edema causes diminished activity, and the cortex is diminished as well. And there's the big vasogenic edema. So he's got a high left frontal kind of centrum semiovale metastasis. This was a lung cancer. Obviously, you would call the physician very soon. Here's another metastasis. Looks a little hyperdense here on the CT. Same thing, vasogenic edema, positive lesion on the PET, that's melanoma. So what I want you guys to do when you're reading PET CTs, and you're probably already doing this, is de-intensify the brain when you're looking at it, because then you'll uncover these lesions. Sometimes they can be cold lesions and they're actually brain metastases, but you're not seeing the actual MET, but you're actually seeing the secondary effects of vasogenic edema. So be careful of those. And sort of you'll have to differentiate that from previous infarct and look for encephalomalacia versus sort of vasogenic edema. If you ever see this in the middle of the brain here, right where you expect the pituitary gland to be, this is going to be a pituitary macroadenoma every time. So you may be asked this on questions on exams, or you'll see this. I probably see this 1 in 100 patients, PET CTs that we read. Meningiomas are not positive on FDG typically. This is a very densely calcified ossified lesion against the calvarium there, and they usually have minimal taps and trace localization. Contrast that to gallium-68 dotatate, which is a neuroendocrine tumor or a somatostatin receptor tumor agent that we use now instead of octreotide studies, and that will show very positive uptake in meningiomas, because a lot of meningiomas have somatostatin receptors, and there it is, this small little calcified thing there. Look how hot it is on the PET image there, and so that's positive there. All right, the other thing we like to do is necrosis versus recurrent GBM with F18 FDG. So you get an MRI, this patient had a GBM, a high-grade glioma, and they get treated. Surgery, radiation, maybe has some oral medication as well. And then you do an MRI, and your favorite neuroradiologist says radiation necrosis versus tumor occurrence. They can't exactly tell. And so the clinician orders an F18 FDG PET. And so the concept is that if it's tumor, it's viable, it's got GLUT receptors, the FDG will localize. If it's radiation necrosis, it's dead, there's not a lot of activity, there shouldn't be any activity. So you take the PET images, top row, your MRI post-Gatto images, your transaxials, and then you fuse them together, and most of your softwares that you read PET CTs for should be able to do this. In that region of enhancement, right here, this sort of globular enhancement posterior to the right ventricle, looks like there's positive activity. The fusion studies say, yes, it's there. There's a bunch of diminished activity because of previous treatment, surgical resection, a big sort of encephalomalacia there that shows diminished activity. But the conclusion here would be recurrent high-grade glioma. Radiation necrosis would look like absent activity. For bonus points, if you're looking here, those of you who've kind of read a few PETs and CNS imaging, you have a lot of diminished activity in the right cerebral hemisphere. In contralateral cerebellar hemisphere, you have diminished activity. So that would be crossed cerebellar diaschisis. There's a little anatomy lesson, motor strip crosses in sort of the midbrain there. And so if you have issues in one hemisphere, you will have contralateral diminished activity because of the white matter tracts in that contralateral cerebellum. Always look for that. Us nuclear folks love this concept and love showing it because it's sort of anatomy meets physiology meets kind of, pathways. And so here's an example, diminished left cerebral hemisphere, and there you have it, the right cerebellar hemisphere is diminished activity, and so that's a contralateral thing. You may be shown something like this, kind of a quiz situation, and say, what do you think? You see obvious no mass here, no encephalomalacia. I will give it to you and say there's nothing anatomically wrong with the cerebellum. What is happened elsewhere in the brain, and you can say the left cerebral hemisphere has some issues. All right, epilepsy. And I apologize, I'm going fast, but we've got a lot of stuff to cover, and I want to make sure I touch on everything. So the two things we're looking for are ictal or interictal regions, either on SPECT CT or PET CT. And so ictal regions are hyperperfused and interictal or hypoperfused. Makes sense, right? If you have an epileptogenic focus, it's going to get more blood flow, and during the interictal phase, it may have diminished flow. So usually we do ictal SPECT and interictal SPECT or interictal PET. And these patients, when we do ictal, we're waiting for them to have a seizures that are hospitalized. We're monitoring EEG, and then we image them. Interictal SPECT can be done anytime. They just have to have no seizure for several weeks is kind of what we require. It may be different at different institutions. And so you have to be told if you're being shown unknown cases what you're being asked to look at. Is this an ictal or interictal? someone shouldn't just put up images and say what's going on, because a lot of things can look hot or diminished on some of these studies. So we would say this is an ictal speck, what's going on, and you would come and see this kind of this pinkish brightness here in this rainbow color display, and you would say that's probably the epileptogenic focus on this ictal speck. If you're told this patient has not had a seizure for 2 weeks, they come in for an interictal speck imaging, what's going on, you can see both on the transaxial and coronal images, there's diminished activity in that mesial temporal, right medial temporal lobe, and that's going to be your most likely source of their seizure focus, and you would call this a interictal speck with epileptogenic focus, likely in the mesial right temporal lobe. All right, we're going to jump to CSF imaging. Little joke for, I guess, healthcare these days. CSF, we all know, made in the choroid plexus. There's about 120, 150 cc's of CSF in the ventricular system, the CSF space. 40 of it is in the ventricular system. That's kind of the pathway. I won't go through all these points, but we know where it flows. You read a lot of brain MRI. So the indications for doing nuclear medicine CSF imaging is NPH, normal pressure hydrocephalus, CSF leak, or shunt patency. So we'll cover those three. The radiopharmaceuticals, I need you to understand, are indium-111 DTPA and TEC DTPA. Each one has its own half-life, and KEV, or the energy that we're aiming for imaging. So know those things. This is kind of the dosages that we use, a lot less of indium and 1 to 3 millicuries of DTPA. And so what are the normal findings? So at 2 to 4 hours, we're going to see the basal cisterns if we're doing a CSF study. By 24 hours, that activity that you injected in the CSF space through a lumbar puncture should ascend over the convexities and should not appear in the ventricles. People have reported at 4 hours, 6 hours, you can transiently see the lateral ventricles. There's debate whether that's always abnormal or sometimes normal. But in the end of the day, image to 24 or 48 hours and document the convexity showing up. Here's a normal CSF flow. You see the basal cisterns. You see it start to try to ascend. By 24 hours, you have it fully ascending over the convexities, bathing that subarachnoid space beautifully, and you do not see a heart-shaped thing in the middle of the head known as the lateral ventricles. NPH is when you don't see the ascent all the way over. In nuclear medicine, you kind of have to squint your eyes and kind of look at it sideways, but the top of the head's over here. You're not seeing it go over the convexities. You see this little heart-shaped thing show up here. That's your friend, the lateral ventricles. Whether it's there at 4 hours or here barely at 24 hours, it's still abnormal. This would be normal pressure hydrocephalus. Another example of normal pressure hydrocephalus does not ascend to the vertex, still has some activity in the ventricles there. That is abnormal. CSF leak. All right, so sometimes you have patients who've had trauma or surgery, and they come and they have otorrhea, rhinorrhea, and it's not just your regular kind of infectious inflammatory process, it's actually CSF leaking. So we do, again, inject the tracer in the subarachnoid space through a lumbar puncture, and we can image, and we can do a pledget study where you put pledgets in their nasal cavity in the kind of inferior, medial, superior turbinate regions on both sides and both nasal cavities, and then do some tests on it. And the concept is, one, if it's for imaging, you may see tracer come out of where you expect the CSF space to be. And that would be, if they're having otorrhea, obviously you're going to look very closely at the ear region. If they're having rhinorrhea, you can do lateral images and look for it coming out the nose. And I'll tell you, in the 15 years I've practiced as an attending in private practice, I've never seen this as a positive study on imaging. It just never happened. It's just a small leak. And if they're gross leaks like that and they know it, the surgeons have already taken care of it. These are small suspected leaks. And so the pledget studies where we really can be very helpful. So you put the pledgets in and then you remove them at certain times, 4 hours up to 24 hours. And as you remove them, you take the blood sample and you do counts both on the pledgets and the blood sample. And because when you inject the CSF with the tracer, some of that CSF will be reabsorbed in the blood. You will have some indium-111 DTPA floating around in the blood, so that's why you need the blood sample to make sure this is not just background, a little bit of leaking of blood cells into those pledgets. And the ratio of the pledget to serum, meaning when you pull that pledget out, you throw it in a well counter, not a dose calibrator, but a well counter. You're looking for a 1.5 to 1 ratio, or a 1.5 ratio. Busy slide. All I'm showing you here is you got all these pledgets, you got all the counts. Someone did a nice little graph here. And the sample to serum, meaning your sample pledget to serum ratio on the right is less than 1, so no leak. On this side, it's 1.62. Someone decided to go to the hundreds place there to 1. So that's a positive study. So you could be asked about what's the ratio or what are we looking for and those kind of things. Is 1.5 to 1 is the ratio. All right, shunt patency. We're looking for shunt patency in folks who have VP shunt or VA shunt, ventricular atrial shunts, and they started having progressive dilatation of the ventricular system, or they're having some other issues and they figure out they're having shunt problems. So you do an x-ray, you've seen all the x-rays looking for kinks and looking for discontinuous limbs or the catheter in the subcutaneous tissues. You've screened that. Now they've said, come help us make sure there's no occlusion. So you inject the reservoir. The reservoir's in the scalp somewhere. You inject DTPA. Now I put a little star there is because some institutions you cannot get sterile DTPA. And if you can't get sterile DTPA, you should do indium-111 DTPA. Make sure it's sterile and pyrogen free. All right. So you put in the reservoir, you occlude the distal limb, the part that's going to the atrium or the peritoneum, and you make sure reflux is back into the ventricles, make sure that part of that catheter is not occluded, and then you inject it and let it freely spill into the atrium or into the peritoneum, and you're looking for occlusion. So a normal study, this is a VP shunt, they've already done checking the proximal limb. There's the head and there's the reservoir and there's this nose-ish area there. So we inject that, goes down and freely spills into the peritoneal cavity. That's the liver, that's the right collar gutter, that's patent. You inject the reservoir, you check, it goes into the ventricle. Then you say, all right, let's inject and go freely down. You image a couple hours, 3 hours, 4 hours go by and nothing moves. There's shunt malfunction and you can kind of tell them where it kind of stops. SPECT CT may be helpful. All right, we're going to end on dementia here, and we're going to talk about all the tracers, a few new tracers, and a few things on the horizon. I'm only going to concentrate on these 3 things, which I think most residents and fellows should understand. Alzheimer's disease, frontotemporal dementia. I wrote multi-infarct dementia. I don't think I have a case of that, and Lewy body disease as well. All right, so Alzheimer's disease, here's the facts. We know it. It's terrible. It's the most common cause of dementia. Really no true therapy for that. We have some disease modifying things, maybe some symptomatic help, but not real disease treatment for this. And a lot of people are on preclinical and clinical pathways right now to figure this out, because that's a big problem for our society right now. So anyway, Alzheimer's disease, what I want you to remember is temporal parietal and posterior cingulate gyrus hypometabolism. All right, that's what you're looking for, hypometabolism, which relates to diminished tracer in temporal parietal or posterior cingulate gyrus. So here's a case. Elderly woman, confusion and memory loss. So this is how it's displayed. So you're going to see black and white, and then projected on there are anything's over 2.5 standard deviations based on some normative population in some of our display protocols here. And so it's showing you where there's diminished activity. It's doing all the work for you. It takes the kind of the guessing game out of it and the squinting, and it shows you all along that posterior cingulate gyrus there's diminished activity. Here's cross-sectional. I've kind of got an ROI over the posterior cingulate gyrus. You can see sort of normal activity. You can see it's diminished bilaterally there, coming down. And there's that purple thing that's showing you it's at least a couple standard deviations down. So this is early Alzheimer's disease. The thing you need to understand is posterior cingulate gyrus is very specific and can be seen very early in Alzheimer's disease when we're doing FAT and FDG PET-CT. Advanced Alzheimer's disease will show it everywhere. Even the frontal lobes can be involved. So it sometimes becomes hard when you're trying to differentiate that from frontal temporal dementia. But this patient actually has posterior cingulate gyrus, looks like it's down. So it helps you push your diagnosis towards Alzheimer's disease. All right, frontotemporal dementia. You're going to see diminished activity in the orbital frontal, dorsolateral prefrontal cortex, anterior cingulate gyrus, as opposed to the posterior cingulate gyrus, and the anterior temporal lobe. So think of frontotemporal, all frontal, anterior parts of the temporal lobe, anterior parts of the cingulate gyrus, and obviously the frontal lobe. All right, and so here's a woman who comes in progressive cognitive impairment, word finding and constructing sentences. So we get the SPECT or the PET images, and it's a rainbow color again, and here's nice dark red there, and you can tell that it's diminished activity in the frontal and the left temporal, frontal and left temporal coming down and all the way down left temporal. So this is, which everything in radiology, we look for symmetry and asymmetry. In fact, dementia can be very asymmetric. And here's the sort of collage of those images I was showing you. Here's another way of showing you, and this is called cortical surface projection. Anything that's diminished greater than 2.5 standard deviation is now projected as whatever color you chose. And this is this hot thermal color I chose, and it's showing you all on the left frontal, temporal, kind of coming back towards the parietal lobe there. All of that's down. And so this is a classic, very asymmetric frontotemporal lobe dementia, asymmetric to the left. All right, dementia with Lewy bodies. Some of you may be surprised to hear it's the second most common cause of dementia. It always catches a few people by surprise. So Alzheimer's and then this. And so the key is that FDG PET can show you lateral and medial occipital lobe diminished activity or hypometabolism. That differentiates itself from Alzheimer's disease. Otherwise, there are similar findings in Alzheimer's disease and Lewy body disease, dementia with Lewy body on FAD and FDG PET. And so it kind of parallels their clinical presentation. Again, this is nice to know, a little clinical correlate here, is that a lot of these patients have visual hallucinations or impaired visual attention. So it kind of makes sense to remember that the occipital lobes are involved. So here's a classic case of Lewy body dementia. Frontal lobes look good. On this lateral, I'm coming down here, temporal lobes look good. And then look, occipital lobes extending kind of into the parietal lobes diminished. And so in our little friend that does all the work for us and outlines the occipital lobe and shows you that it's at least 2.5 standard deviations below normal mean, spits out all these Z-scores for you. This is all diffuse Lewy body disease. This is dementia with Lewy body, dementia. All right, so we asked this question early on, and gosh, I think you already know the answer now, and hopefully you knew it before, that if which of the following structures is most commonly affected with DLB, and that's the occipital lobes. All right, going to introduce sort of amyvid, which we use more common, but there are other ones. This is amyloid, beta amyloid imaging. All right, so we've come out with 3 tracers. They have been approved by FDA, but insurance companies haven't completely embraced. So in our private practice, we don't do a lot of this, but maybe at your academic places, you're doing a little bit of this. But it's very different than FDG, that you don't need to monitor their glucose. You image right away, and you're looking something different than what a FDG is going to look like. I'm not going to read this slide. I'm going to show you pictures. So a normal study, it's opposite of what we see in FDG. Most of all the activity is in the white matter. You don't see the gray matter here. All right, so this is normal. People who have amyloid deposition in their brain, and it can happen with age, but people with Alzheimer's tend to have this as well, and way earlier than just normal age progression, will lose this gray-white matter differentiation and have activity throughout the gray matter here. And so at your stage, I think just looking at normal, where it's all white matter, and abnormal, you lose that gray-white matter, kind of looks like a blurred study. You'd have to be told, if you're seeing an unknown case, you'd have to be told this is an amyvid study being shown to you. I think this is fair game for residents to understand. And just introducing that we did beta amyloid imaging, which kind of tells you if they have it or not. There's new studies and the new things that are coming out. You'll read here and there about tau imaging. And just to tell you that tau imaging is really interesting because it actually predicts where the degeneration is going to happen. All right. And also it shows that the level of uptake will actually correlate with the level of atrophy that occurs down the line. So you can actually predict what kind of symptoms they'll have, what issues they'll have. And so, with all this new precision medicine talk, this is going to be an excellent precision medicine tool if someone comes up with a treatment for this. So then you can actually monitor if the patient's diagnosed it with one of these tau PET CTs, then you can actually watch and see if they're not advancing in those areas, because those areas would have been very susceptible to atrophy down the road. So pretty interesting stuff. Will definitely happen in your lifetime. You'll be reading these at some point. There are the images. I'll just kind of fly through it. And I'll kind of end on DAT scans. And DAT scans, we use it for Parkinsonian syndromes versus essential tremor. I would say one of the easiest studies that we do as far as interpreting them, because it's either, and I'll show you in a bit, they're very, it's a nice study because the target is the caudate and putamen, and that's all you're looking at, nothing else. And so the idea is that this tracer, I-123 ioflupane, binds to the presynaptic regions of dopamine transporters, and people with Parkinson's disease have diminished transporters there, and so it won't bind and have diminished activity. All right, and so you're differentiating a person with a tremor, trying to go from essential tremor to a true Parkinsonian's tremor. And for higher level, you can actually differentiate DLB from Alzheimer's disease, because DLB will have abnormal activity as well. That's Lewy body disease. So patient preparation, we didn't talk about that a lot for a lot of other studies, but you have to definitely block their thyroid. It's a high dose of I-123. Avoid a bunch of medications. This reminds me of MIBG, where you have to look through their entire chart and look for all these medicines. Cocaine on that list just makes me giggle, because you love asking your patients when they last had cocaine. Sorry, that's for Harp. He said make it kind of funny. That's my only joke. I kept it PC otherwise for you, Dr. Beatty. All right, so then we inject the tracer and image a few hours later. This is a normal DAT scan, and literally the pamphlet that describes how to use this study says, look for commas, all right, commas versus periods. So you got to go back to second grade and think, if these look like good commas, which your third grade teacher say these are good commas, obviously that's backward comma, but does this look like a good comma? It does, and that's a normal study. Again, beautiful little, I like to say these are kind of half quotes, right? Quote on each side of the brain, midline brain there. This is not normal. These are periods, all right? You want commas and not periods. So I told you, a very basic study to interpret, pretty nice, clean background, target to background. You're only seeing the things you're looking at, to image, not a lot of background noise there. All right, and so here's some follow-up on those intro cases. We talked about this. Hopefully you knew the answer here, that this was done for evaluate for abnormal brain perfusion or absent brain perfusion. You would say, nope, can't pull, don't do any life decisions on this patient. He still has, or he or she still has brain perfusion. There's a lot of sinus activity, or sorry, the arterial activity you see here. It's beautiful, beautiful blush. You would never say this is absent brain perfusion. This is preserved. Showed this study and told you this patient had some sort of memory issues. It's all in the frontal lobe. And you come down here, the temporal lobes are involved. So this is anterior parts of the brain. So think frontal temporal. So this is frontal temporal dementia on F18 FDG. And hopefully everyone remembers their second grade teacher. These are perfect commas. This is a DAT scan, and you would call this very normal. That's all I got. Be safe, guys. Thank you for joining. Kind of an honor to be the last lecturer. Sad that you could have picked a better person to do this lecture as the last moments of this great series Dr. Beatty put together. So thank you, guys.
Thank you, Dr. Oza, Dr. Connolly. It's really been an honor and a pleasure to bring this series to you. Again, thank you to the APDR staff. It's been a wonderful run that we had. And I look forward to working with all of you in some capacity in the future. And good luck to all the attendees. Be safe.